Assalamu alaikum everyone. Today the topic of discussion is hemolytic anemia. We are discussing anemias, and we have already discussed in the overview portion that whenever a patient present with the signs of anemia, signs and symptoms of anemia, so first we check the MCV. If the MCV fall between less than 80, so it's microcytic. If it fall between 80 to 100, so it's normocytic, and if it is greater than 100, so it's macrocytic. Now we should come to the normocytic anemia in which MCV is between 80 to 100. Whenever we come across such a result, so we can suspect different causes. Further, we can proceed with reticulocyte count. If reticulocyte count is decreased, so we can consider two causes. It can be either chronic kidney disease or it can be aplastic anemia. So for this we check erythropoietin level. If the erythropoietin level is decreased, so it's chronic kidney disease. And if erythropoietin level is normal or increased with pancytopenia, so we called it aplastic anemia. Now if we have normal or increased reticulocyte count, then we check for the signs of hemolysis. If the signs of hemolysis are present, like decreased heptoglobin, increased LDH, increased indirect bilirubin, so we classify it as hemolytic anemia. If there is no signs of hemolytic anemia or the signs of hemolysis and the retic count is elevated, so we can consider blood loss as a cause of the anemia. Now we will discuss the hemolytic anemia and its different classifications. So in hemolytic anemia, MCV will be normal, 80 to 100 femtoliter. It's normocytic anemia. We will have normocytic anemia, reticulocytosis, and signs of hemolysis like decreased heptoglobin, increased LDH, and increased indirect bilirubin. Normal reticulocyte count is 0.5 to 1.5%. What are the etiologies of hemolytic anemia? So we have different types and etiologies of hemolytic anemia. Hemolytic anemia is characterized by excessive breakdown of the RBCs. They can be classified according to the cause of hemolytic anemia, intrinsic or extrinsic, and by the location of hemolysis, intravascular or extravascular. By RBC pathology, we have intrinsic hemolytic anemia and extrinsic hemolytic anemia. In intrinsic hemolytic anemia, increased destruction of RBC due to a defect within RBC. So RBC are defected, due to which hemolysis of the RBC occurs. We can have different causes like RBC membrane defect. We have hereditary spherocytosis and paroxysmal nocturnal hemoglobinuria. Enzyme defects, we have G6PD, glucose 6-phosphate dehydrogenase deficiency, and pyruvate kinase. While in hemoglobinopathies, we have sickle cell, thalassemia, hemoglobin C, and hemoglobin Z. Then, on the basis of extrinsic hemolytic anemias, so we have abnormal breakdown of normal RBC. Here the RBC are normal. So we have different causes like mechanical destruction, autoimmune, alloimmune, immune reaction due to infections, infection causing increased destruction of RBC and increased degradation by the spleen. Then by the location of the RBC breakdown, we have two types, intravascular and extravascular. In intravascular, increased destruction of RBC occur within the blood vessels, while in extravascular, increased destruction of RBC by reticuloendothelial system, primarily in spleen. So in extravascular hemolytic anemia, we have splenomegaly due to destruction of RBC in the spleen. And these are the different causes like toxins, G6PD, antibody mediated, complement mediated, macroangiopathic, microangiopathic. While in extravascular, we have RBC defects like sickle cell disease, spherocytosis, and pyruvate kinase. So we have remember these three SPS, sickle cell, pyruvate kinase, and spherocytosis, which is hereditary spherocytosis. These three In these three disorders, the hemolysis occur extravascular. Also, we have antibody-mediated hemolysis, warm and cold agglutinin disease. So, in these two disorders, we have extravascular hemolysis. Now, clinical features. So, patient will present with signs of anemia, pallor, fatigue, exertional dyspnea, and severe cases, tachycardia, angina pectoris, leg ulcers. There will be signs of hemolysis, jaundice, pigmented stone due to increase in direct bilirubin, splenomegaly, extravascular hemolysis, and back pain and dark urine in severe hemolysis with hemoglobinuria. We will have sign of increased hematopoiesis, mostly in severe chronic anemia, example thalassemia, as we have already discussed in the portion of thalassemia. The bone marrow expansion occur, widening of the diploic space, which was given as crew-cut appearance of the skull bone, and biconcave deformity of the vertebral bodies. Cortical thinning and softening of the bone increase risk of pathologic fracture, and extramedullary hematopoiesis or hepatosplenomegaly will also occur. Now, how to diagnose? So, consider hemolysis in patient with acute or chronic anemia in whom an obvious cause, example bleeding, is not apparent. How we should approach? So, initial lab studies to confirm anemia. First, we should confirm the anemia and then classify anemia by morphology. So, first we do CBC with MCV and retic count. So, MCV should be 80 to 100 and retic count will be elevated in hemolytic anemia. Then we do the hemolysis workup, so which will give us increased LDH, decreased heptoglobin, increased bilirubin, and we can also do urinalysis and peripheral smear. Then to narrow down the differential, we do the DAT, direct anticoagulant test, which is known as direct Coombs test, to narrow the differential. So if the DAT is positive, so it means that this is the antibody mediated hemolytic anemia. If DAT is negative, so it means it is non-antibody mediated hemolytic anemia. We should have to rule out hemolysis in any patient with unexplained anemia, and even if the urine dipstick is negative for blood and jaundice is not evident on physical examination. So still we should have to rule out the hemolysis. If patient has severe symptom of anemia or life-threatening causes suspected, like TTP, thrombotic thrombocytopenia purpura, hemolytic uremic syndrome, DIC, disseminated intravascular coagulation, HELP syndrome, acute hemolytic transfusion reaction, so proceed directly to the treatment in parallel with the diagnosis, because these are considered as emergencies. In CBC, we will have decreased HP, hematocrit, and RBC count. These all three will be reduced. On MCV, we will have normocytosis, typical finding for hemolytic anemia. So, normocytosis is the typical finding. Consider other anemia of chronic disease. If you have an increased MCV, it can also be due to severe reticulocytosis, or it can also occur in hemolysis. But consider other causes of macrocytosis like megaloblastic anemia. If we find MCV less than 80, so consider thalassemia as a cause of hemolysis, or sometime iron deficiency anemia. The WBC count, if it is elevated, so it can be due to inflammation or malignancy, and platelets if decreased, so it can be these are decreased in microangiopathic hemolytic anemia and an E1 syndrome. E1 syndrome is a condition in which two or more hematologic immune cytopenias are present. Most commonly, immune thrombocytopenia (ITP) in combination with autoimmune hemolytic anemia are present. Then we check the reticulocyte count, so there will be reticulocytosis. Because when the RBC count decreases, so bone marrow in response to the decreased RBC count due to hemolysis produce more reticulocytes. So reticulocytosis occur, reticulocyte count in the blood increase. And iron study are usually normal in hemolytic anemia. However, iron deficiency can be seen in chronic intravascular hemolysis. Further hemolysis workup, so no single test can diagnose the hemolytic anemia. We will have different type of combination, like we will have finding of anemia in the presence of accelerated erythropoiesis, reticulocytosis. In addition to the evidence of RBC destruction in the serum and or urine studies is highly suggestive of hemolytic anemia. Typical biochemical findings in hemolysis will be decreased hemoglobin, increased LDH, increase in direct bilirubin, and in peripheral smear abnormality as increased reticulocytes, schistocytes, spherocytes, polychromasia. Schistocytes occur in intravascular hemolysis while spherocytes occur in extravascular hemolysis. And urinalysis abnormalities like the hemoglobinuria, hemocystinuria, and urobilinogen. So now we should check the serum studies. So heptoglobin will be decreased in both extravascular and intravascular hemolysis. Heptoglobin is decreased because it binds the free hemoglobin. And then LDH is elevated in both, but it is more in intravascular than in extravascular hemolysis. Then we have indirect bilirubin. So hemolysis occur, Hb release and heme is catabolized into indirect bilirubin. It is more common in extravascular hemolysis. And in intravascular it can be normal or slightly elevated. And peripheral smear, so we will have different findings. So it's used to detect the abnormal RBC forms, intracellular microorganism and inclusion bodies. In intravascular hemolysis we will have increased reticulocytes. Also in extravascular we will have increased reticulocyte count. Hence bodies and white cells will be present in G6PD deficiency. Schistocytes will be present in microangiopathic or macroangiopathic hemolytic anemias. An intracellular organism will be present, for example, in malaria, babesia, and Bartonellosis. In extravascular, we will have increased retic count, we will have spherocytes, in a hereditary spherocytosis, and immune-mediated hemolysis, like warm autoimmune hemolytic anemia and hemolytic transfusion reactions. So spherocytes are present in both hereditary spherocytosis and immune-mediated hemolysis. To differentiate between them, we can do the direct antiglobulin test. As hereditary spherocytosis is non-immune mediated, so that will be negative, and hereditary spherocytosis violet will be positive in immune mediated hemolysis. Then we have RBC agglutination and cold agglutinin disease. Sickle cell will be present, and sickle cell disease target cell will be present in sickle cell and as well as thalassemia and HBC. So target cells will be present in these three diseases: teardrop cells in thalassemia, and we have HB crystals will be present in HBC disease, and smudge cells will be present, which are known as Gumpert shadows, in CLL, chronic lymphocytic leukemia. Heptoglobin level can be low in both intravascular and extravascular, and therefore should not be used to differentiate between the two. Now, what will be finding in the urine study? So we will check for hemoglobinuria. Urine dipstick is positive for heme, but no RBC are seen on microscopy. Early and transient marker of severe intravascular hemolysis. There will be brown color urine, mostly occur in intravascular hemolysis. So it will be present in intravascular and usually absent in extravascular hemolysis. Then we look for the hemosideриnuria. So filtered HB is reabsorbed by proximal convoluted tubule of heme. Heme iron is removed and stored as hemosiderin. Hemosiderin containing proximal tubule cell are sloughed up into the urine, late marker of severe intravascular hemolysis. And urine will be brown color, typically seen in marked intravascular hemolysis. So the hemoglobinuria and hemosideриnuria are usually present in intravascular hemolysis, where they are absent in extravascular hemolysis. The third bilinogen, increase in direct bilirubin, increase bilirubin breakdown in the gut, increase urobilinogen reabsorption into the enterohepatic circulation. So excess urobilinogen enter the systemic circulation, urobilinogen is excreted in urine, mostly occur in extravascular. So this is mostly present in extravascular, or usually absent in intravascular hemolysis.